Good evening. Welcome to Ask the Expert, presented by Mary Washington Healthcare. Tonight's session is the second of a three-part series featuring cardiologists and cardiovascular providers from Mary Washington Medical Group. During this session, our experts will discuss symptoms, diagnosis, and treatment of heart valve disease. We will also explore transcatheter aortic valve replacement, or TAVR. This program is called Ask the Expert, so of course we will answer your questions live. Our providers want to hear from you. To submit a question for our panel, simply drop it in the chat here on Facebook. Today's panelists have a wealth of experience in cardiology, including cardiac procedures and cardiac surgery. They truly are experts in their field. Let's meet them. First, we have Dr. John Cardone, who is a highly trained and experienced cardiothoracic surgeon. His skill and success in performing over 3,500 cardiac-related procedures are a prominent contribution to the award-winning Advanced Cardiac Care team at Mary Washington Hospital. His specialties include removing cardiac tumors, coronary artery revascularization, complex valve repair and replacement, open surgery of the thoracic and abdominal aorta, and minimally invasive procedures, including TAVR. Next, we have Dr. Clarence Findley, who is an interventional and structural cardiologist. He is skilled in the medical treatment of cardiovascular disease and the procedural treatment of heart attacks, congestive heart failure, and valvular heart disease. Dr. Findley is certified by the American Board of Internal Medicine in internal medicine, cardiovascular disease, and interventional cardiology. He is a fellow of the American College of Cardiology and the Society for Cardiovascular Angiography and Interventions. Finally, we have Mike Brown. Mike is the program director of the Cardiac Surgery and Structural Heart Program at Mary Washington Hospital. He is also the chief perfusionist at Mary Washington Hospital, playing an important role on our cardiac care team. Mike came to Fredericksburg in 1994 after completing his training at the Cleveland Clinic and working at the University of Pittsburgh Medical Center. Welcome, everyone. Thanks for joining us tonight. We're going to start the program by answering a few commonly asked questions that our providers hear in their practice. So, Dr. Findley, let's start with you. Can you share with our community the different types of heart disease and how you treat them?
Sure. So I think probably a way to start is kind of to think about the symptoms that we oftentimes see and treat, so that a lot of the patients would recognize probably that a little more readily. So lightheadedness, dizziness, shortness of breath, chest discomfort, and that really sort of encompasses any sort of discomfort in the chest that is typically not there. So whether it be pain, burning sensation, gripping sensation, pressure, heaviness, et cetera, all of those things are things that we like to sort of investigate and ensure that it's not cardiac in nature. Valvular disease is another item that we typically will investigate, and most of these patients will present with murmurs. And so a lot of the patients who will tell you that they've had murmurs from a child, these are things that need to sort of be tracked for us to ensure that they don't become issues in the future. Something else that we oftentimes treat is something called syncope or passing out. And so that's another potential sign that you may have some cardiac disease that needs to be addressed. Palpitations, holes in hearts, heart rhythm problems, these are all sort of under the rubric of what a cardiologist does and what we see on a daily basis. Multiple tools and multiple tricks for us to first diagnose and potentially treat. Up to and including things as simple as an EKG, stress test, echocardiogram, CT scans now, which has become, has sort of revolutionized the field and helped us quite a bit in what we're able to do, all the way up to interventions. And so that's putting in stents, closing holes in hearts, replacing heart valves, and oftentimes engaging our cardiothoracic colleagues like Dr. Cardone and helping to get these patients the best care that's possible.
Thank you, Dr. Findley.
Absolutely.
So Dr. Cardone, when we're talking about some of these treatments that patients might need to help their hearts live long and healthy, can you talk to us about some of the procedures and surgeries that you and your team perform?
Sure. Well, there's a number of different procedures that I'm involved with. The open heart, which is sort of the one that the classic train one that I started with, consists of going in through the breastbone and exposing the heart, using Mike and our perfusion team to keep the patient alive while we stop the heart and actually operate on the various parts that may need to be taken care of, the bypassing blocked arteries or opening the heart and fixing valves, that sort of thing, or fixing holes between the chambers of the heart. And then we also do operations on the great vessels, the blood vessels that lead out of the heart. Usually that's the aorta. That's the main culprit there. If there are any types of aneurysms or dissections or tears in the wall of the aorta, we operate on those. And then the other things that we do now are we work hand in hand with our cardiology colleagues like Dr. Finley for the transcatheter valves. So instead of opening the heart to replace the aortic valve, we would do a procedure where we go through the arteries in the legs and we implant the valve and replace the valve from the inside. And it truly is a two-person procedure with a surgeon and a cardiologist working literally side by side to take on that type of procedure. So, sort of a thumbnail of what we do.
Great, thank you. We built a hybrid operating room at Mary Washington Hospital several years ago, specific to the TAVR procedure. It's quite a feat to behold, to see all of the equipment and the providers, like you said, working side by side. Mike, you've been with Mary Washington Healthcare for a long time. And in fact, you were part of the team that started the cardiac surgery program here at Mary Washington Hospital. From your perspective, can you tell us how the program and the technology have changed since it started?
Sure. When I came here in 1994, we were largely tasked with starting a general adult cardiac surgery program here. I came here with John Armitage from the University of Pittsburgh, and pretty quickly we were able to establish ourselves as a pretty high quality program. He was an excellent technician and really specialized in doing multiple arterial grafts, which was kind of novel at that time in the 90s, using radial artery bypasses. And that's something that we do here now at Mary Washington Hospital. And compared to other programs across the region, we're probably one of the more aggressive users of arterial bypasses. But when you look at the change or the evolution of cardiac surgery and cardiac services, the one thing that you can see is that technology really advanced itself. So as Dr. Cardone was speaking about, repairing holes between the chambers of the heart, it's exceedingly rare we see those procedures. They're often done by structural interventionalists like Dr. Finley. And the one thing that I remember, 30 years ago, 35 years ago when I got into this, there was that talk that, we would never need to use the heart-lung machine to do heart surgery at some point. And I thought, well, I hope at least I get to the point where I can retire with this job. But the reality of it is that we are at that point where we are, technology has advanced itself. I think the stent technology that came out in the 90s for coronary stenting really was the breakthrough technology. It was a bare metal stent, then it became a coated stent, and then whether it was by choice or not, the new transcatheter valves that are out now, the transcatheter valve or TAVR programs out now, they've taken stent technology, obviously at a larger format, and they've been able to take the surgical valves that we've been implanting for decades, and they've learned how to mount that onto a stent, very similar to a coronary stent. Obviously, it's just different technology, but they've been able to take that technology and apply it to the interventional side, and we now perform those procedures in a heart team approach where Dr. Finley, Dr. Cardone, and our other surgeons and interventionalists and our cardiac imagers from radiology, we all sit in a room with a multidisciplinary team. We review those patients and we say, what's the best choice for this patient? should this patient undergo a surgical aortic valve, or should they undergo a transcatheter valve? And when we do these procedures, they're doing them in tandem, which is pretty amazing. So we have anesthesia, we have interventional, we have cardiac surgery, perfusion, and both of the support teams are the cath lab team, and we have the CVOR team, and it's really a major production, but we do it on a weekly basis, and we've in short order become very successful at it. Our program was late to that game. We started in 2016, and most of the programs, the big centers in Virginia, were doing them. They were part of the original trials in 2011. But very quickly, our program became a 3-star program. So when you think of technology in that regard, it was quite an investment for us. We invested about $5 million to build that hybrid room and kind of restructured the second floor of our hospital. And that really kind of opened the doors. Now we're expanding EP. We're building a third EP room. We are opening up an extra cath lab. And the one, I think the beauty just to the Fredericksburg region is that the growth in the surrounding counties has been able to sustain our heart surgery growth and our volume, whereas in other institutions, they've seen their cardiac surgery volumes actually go down because of that shift to the transcatheter procedure. So for us, we've been very fortunate. We've got the support of interventional cardiologists, and our surgeons have been able to stay pretty busy doing such.
Yeah, that's an incredible overview of the program, Mike. And from what you've described, it really sounds like there's a large group of people in this procedural area, all focused on one patient. Yeah. And it sounds too that you were talking about different approaches to treatment. That it isn't a one size fits all. That each patient is seen as an individual, and we look at the treatments and options that are most suitable for each person as an individual. We do have a couple of questions specific to TAVR. When we're talking about transcatheter aortic valve replacement, we're replacing a part of the body, right? We're fixing something that doesn't work quite right. So Dr. Cardone, there are people wondering how long these valves will last. Is that something you can address for our community?
I can try. The valve that we use predominantly at our program, made by Edwards, has been around since the 1990s. That valve, it's a bovine pericardium valve. So it's made out of the outside sac lining of the heart of a cow, and it's hand sewn onto a stent, a forming device by people in a very incredible lab out in California. I think it's in Irvine. And then the whole thing is mounted onto a metal stent, like Mike said, to be implanted. Now, those original valves, the Edwards valves, have been around since the mid-1990s, and there's some very well-written papers that have been followed out over time showing the longevity of those valves. When they're sewn in by hand, the way that I was originally trained, in someone over the age of 65 or 70, that valve should last 15 to 20 years, we would expect. Younger people, the valves tend to not last as long. The theory has always been that because their hearts, you could think of it as their hearts beating more vigorously, it tends to damage, if you will, the valve a little bit more, so that it reduces the longevity of the valve. Now, taking that same valve, squishing it down onto a stent and inserting it through a 14 French device up through the arteries is a little bit different. That's only really been around for a little over 10 years now in this country. And so, for me to say with absolute certainty that we would expect those valves to last as long as one sewn in by hand, when we're talking about 15 to 20 years, it's a little disingenuous. But so far, the data would suggest at the midterm that those valves should last about the same life expectancy. So,
Right.
you know, a decade, maybe 2 decades, depending on how old you are when they're put in. That would be what we would anticipate.
Great. Thank you. And as a follow-up to that, so we're talking about a minimally invasive procedure. When we're doing TAVR, we're not cutting someone's chest open. So folks are wondering, what happens to the old valve? Does it stay in there? How does the new valve work with the old valve?
Is that for me or?
Yeah, Dr. Cardone,
Okay,
please weigh in.
sure.
And Dr. Findlay, if you have any follow-up comments, we'd love to hear those too.
I'm just curious. I'm not sure. I know you had a video of the Edwards valve being put in. I think that can kind of help describe it. But the short answer to your question is this: when we do the open surgery, I go in and actually cut out the old valve and all the little calcified pieces that come with it, and then sew the new valve in by hand. With this, when we go up through the artery in the leg, this valve and stent goes into the native valve, the valve that's in place already, and literally squishes it into the wall of the aorta, pushing it out of the way. So it sort of uses that old valve as an anchor, if you will, for the transcatheter valve to have something to hold on to so it doesn't get ejected and moved out of position.
Great. Thanks, Dr. Cardone. Dr. Findlay, did you have anything to add?
No, I was going to say the same thing. That calcium is sort of, like you said, an anchor. For the first question you asked with respect to longevity of the valves, there's actually been some more recent data, 2023, looking at the 5 and 10-year lifespans of these valves. So that's a lot of these valves haven't really been around for much longer than that, and as best we can tell, the lifespan of these is as good as the surgical valves, much like Dr. Cardone was saying. And typically, we quote patients about 10 to 12 years is sort of that range. So this is all in agreement with what Dr. Cardone was mentioning as well.
Thank you.
Yeah, the only thing I would add to that, Emily, is that, and it's in the same vein as how Dr. Cardone explained how we implant into the native valve. If somebody has had a previous bioprosthetic surgical implant, you can have a reoperation without having to open your chest. And I think that's probably one of the biggest benefits of this procedure, outside of, if it's your first time procedure, if you've just been diagnosed with aortic stenosis, and you're young, there's a lot of speculation. Should you have an open surgical procedure and then follow that with transcatheter valve, or should you start with a transcatheter valve and then move towards surgery later on? This procedure really opens up doors that we really didn't have before. But if you've had a bioprosthetic valve for 10, 15 years and you're 70 years old, we can actually do a transcatheter valve on that patient with a bioprosthetic valve. It only works with bioprosthetic valves, not mechanical valves. But that really has changed the equation for a lot of these people that need reoperation, because anytime you have to open the sternum where there's a lot of adhesions, it just is prohibitive risk. And so the new valves that are out now, the new surgical valves that we put in, if we end up having to do a combined procedure where we're doing bypasses and maybe some other procedure and an aortic valve, the new valves actually, there's something called an annulus to the valve. It's really just a structure that holds the leaflets together, but they've developed this surgical valve so that that structure will articulate and it'll expand. And that way, when we go in and implant a transcatheter valve, it allows you to maximize the size of that valve, which is important because you want to be able to get a good sized valve in there so that they don't have a pressure gradient across that valve. So just want to add that for anybody listening out there who may have had previous surgery.
Yeah, that's really helpful, Mike. Thank you. And it kind of speaks a little bit to a question that we have here out with our live audience about is it ever too early or too late to get a valve replacement. So I think we've touched on that a little bit with the life expectancy or the duration of these actual of devices. But to the point of it, is it ever too late to get a valve replacement? That maybe speaks to some of the major risks or complications that we would discuss with patients. Mike, I remember the first patient that came through and had a TAVR procedure. She might not have been able to have open heart surgery, but a TAVR procedure worked great for her. So maybe you could talk a little bit about some of the risks and complications that would count someone in or count someone out for TAVR.
Well, I'll let Dr. Cardone and Dr. Finley talk about that. But what I would say is that when we first opened our program, like most programs, we were doing high risk and non-operative patients, and so that's what was FDA approved at the time. And so, our first couple of patients, we were amazed at their improvement in just their ADLs, their ability to ambulate without without oxygen. They just saw an incredible improvement in quality of life. And then when moderate risk and then low risk was approved, then we started getting patients that were, I don't want to say a higher quality of patient, but a lower acuity of patient, certainly. And so nonetheless, we have this weekly conference where whether you're high risk or moderate or low risk, we're still having that discussion and we're talking about those potential complications. But I think Dr. Finley and Cardone can talk about that, because there's different components to that. And part of it is your access to getting the valve in and what are your prohibitive risks. So I'll let them address that.
Okay. Thanks, Mike. So Dr. Finley, you want to start us out?
Sure. I think you're just kind of thinking globally or in the general sense, not getting into patient specifics, but the guidelines really say that as long as the patient has a life expectancy greater than 1 year, all right, and I think as a community, myself and Dr. Cardone or whatever interventional and surgical colleague believes that patient will actually benefit from it. So not someone who's bedridden, bedbound, and not really going to benefit from that valve going in. As long as everything else meets the right criteria, they're not too old to have the valve, right? So again, the sort of the minimum criteria is making sure that the patient can live longer than a year and have something that you want to restore them to, at least in my mind. And from a too young standpoint, that's a big debate in the field. And a lot of the surgeons, and I'd love to hear what Dr. Cardone's thoughts are, but if you have a 50-year-old gentleman coming in or female coming in and needs a valve, I think some of us would try to push for that patient to have a mechanical valve surgically, barring any other issues, and they'd get the sort of greatest duration out of that valve, 20, 25 years. And then we could look at a reoperation and determine where to go from there. So that's a huge debate in the field, but suffice it to say, technically, from a technical standpoint, no one's too young. And the too old is only really limited by life expectancy. So I'd love to hear what Dr. Cardone has to say.
Yeah, it's funny when before TAVRs came out, when it was still just sort of a fantasy. I've been at this almost 30 years now, so I have a little perspective on it. Trying to talk someone who was in their 80s into having an aortic valve replacement, even if they were very symptomatic, was a chore. I mean, it was difficult to get people to agree to surgery, even though, we could stand on our head and tell them how much better their lifestyle was going to be once they recovered from the surgery. And it was a challenge. Now, having patients and being able to bring them in, do this transcatheter valve, send them home in a day or two, and they already start reaping the benefits of the improved hemodynamics almost immediately. It really has changed the way I think of valve replacement in the aortic position. And I've even had, one of the most interesting conversations I ever had was with my personal primary care doctor, who does a fair amount of gerontology. And he told me, look, John, he said, I've had to change the way I approach my elderly patients with aortic valve disease, because there were lots of them I'd never even was going to send to you because I didn't think they would ever get through an operation. But now we send them in, you guys take a good look at them, you make your best decision. And it's really changed the way that I approach gerontology, the way I approach aortic valve disease in the elderly. So yeah, I mean, I think it has changed the way we think. The fact that we do it together as a team is also a big change that I've seen, and I'm happy with that, because I I guess I'll shamelessly promote our upcoming valve symposium. I'm doing a talk, and the title of it is Surgical versus Transcatheter Valve Replacement. Yes, no, and I don't know. that and that's really the way I feel sometimes at our multidisciplinary valve conference. I sit there and say yes, no, and I don't know. And sometimes it's just it has to be a group think and a participation decision.
Thanks, Dr. Cardone. I love the theme that seems to be coming out of all of our panelists' comments tonight, which is that it really does take a team behind every patient to help that patient get back up on their feet and feeling their very best. We're coming up towards the top of our time. I think we have time for just a couple more questions. Dr. Cardone, I want to go back to something that you said just very briefly a moment ago, and that was that a hospital stay for a patient who's had a TAVR procedure is 2 or 3 days. Is that right?
Yeah, and that's actually fairly conservative. I mean, there are places that have written papers and routinely send people home that night or the next morning, and we do it here. A fair number of our patients go home the next day. So
Wow.
you know, it really is a it really is a sort of a large heart catheterization procedure at that point. We watch them for any of the initial complications that might arise, and once they clear those hurdles, they're ready to go home. That's as opposed to the open heart procedure where we would, you know, the bare minimum stay is going to be at least 4 or 5 days after one of those. And, you know, I'll be honest with you. I mean, I've been doing this a long time. Those patients are sore for a good couple of weeks afterwards, depending on the person and their tolerance for pain. So it makes a big difference in their lifestyle and their recovery.
Well, thank you. Mike, you had some comments?
Yeah, I didn't want to put my thumb down like I was saying that was bad. Our average length of stay, you know, when you include all outliers, is less than 2 days. But I would say probably 95% of our patients are home in 1 day. You know, we established a fast track. You know, COVID presented a lot of challenges to every health system. But for us, it presented challenges that had more to do with identifying which patients needed to be done now versus that could wait. And that had to do with cardiac surgery, and it had to do with structural heart with TAVR. And so we actually identified, and we created an algorithm to identify our patients that were at risk for sudden death, because there are a number of patients out there with aortic stenosis. And Dr. Cardone made a point about his gerontologist, but there's more than, you know, 250,000 to 500,000 people that are walking around out there with undiagnosed aortic stenosis that are at risk for sudden death. I mean, it's once you have aortic stenosis and it becomes severe, and you start to have changes in your heart function, I mean, you're at risk for sudden death. And so we identified those patients and expedited getting their transcatheter valves done. And it forced us to ask a few key questions, like how could we improve just our workflow so that we can safely get these people home and back to their environment. And we found that people did better when they didn't go to the ICU. And that's national data that showed that, especially in our elderly population, they didn't get the delirium, they didn't get the polypharmacy. So we were fast tracking probably about 75% of our patients to a post-anesthesia care unit. And as long as they were stable after 4 hours, they went to our step-down floor, and then they were discharged home the next day. And so readmission rate went down, delirium went down, complications go down. And I think a lot of that has contributed to our 3-star TAVR program. So 3-star is the highest rating. We're the only program in the state of Virginia that has a 3-star transcatheter valve program. But again, most people are home within a day. And I'm not talking about the 60-year-olds. I'm talking about people that are in, 80, 90 years old. They're home the next day and they want to go home. They're ready to go home because they're functioning even at a better level in 24 hours after they've had their valve done. So it's pretty impressive.
Yeah, that's amazing. And Mike, you mentioned the 3-star rating for our program, and I want to come back to that. But a lot of these comments about, the improved patient outcomes and the shorter hospital stay supports Dr. Findley's earlier comments about, patients, getting up and feeling better very, very soon after having a procedure done, which kind of leads us into another question. And Dr. Findley, this is for you. What kind of follow-ups can a patient expect after what sounds like a very brief hospital stay for a cardiac procedure like TAVR? How often would you see them in your office, and would you send them to other programs, like, for example, cardiac rehab?
Sure, great question. So I'll break it up into 3 buckets. The first bucket will be the TAVR bucket. Those patients are typically seen at about a month with a follow-up scan or echocardiogram to assess valve function. And around that time point is when they get enrolled into a cardiac rehab program, which typically is 36 sessions over 12 weeks, or it can be 36 sessions over 18 weeks. So 2 to 3 times per week. And we see tremendous benefit with that, not only from a physical functional standpoint, but also from an emotional and mental standpoint. And then after the 1 month follow-up, there's annual follow-up. And depending if this person is coming from another cardiologist outside of the region, that cardiologist will sort of follow that individual on an annual basis with annual scans just to make sure that the valve is functioning fine. For our post-surgical patients, typically Dr. Cardone's team will see these patients at least twice within the first month. If I'm not mistaken, Dr. Cardone, I think around 2 weeks and 4 weeks. And then right around the 4-week mark is when I kind of step in. I typically see my patients between 4 and 6 weeks. Generally around that time, they are starting cardiac rehab, which is the same algorithm that I just discussed. And then my personal paradigm is to see them at 1 month post, 3 months after that first 1 month visit, 6 months, and then annually after that. So I keep a close eye on them for the first 6 to 8 months, just to make sure that they're tracking okay. And I think it's comforting for the patients. It gives them security. They know they have multiple touch points, and they feel assured that when they reach that, okay, I'll see you in a year, they're at a point where they can take that leap without having to look back. And then from a cath standpoint, so these are individuals who come in and get, let's say, stenting done. I typically see them within 2 to 4 weeks after the procedure in clinic. And then again, 3 months, 6 months, and then we do annually after that. And I don't necessarily do any additional follow-up imaging as far as echoes or stress tests unless they have symptoms. And by guidelines, I wait about 5 years in the absence of symptoms to reassess them.
So it sounds like we're very hands-on with our patients from the time that they're receiving sort of at the time care in the hospital with the huge team that's there with them, all the way through to their post follow-ups in the clinic. That's amazing. We don't have a whole lot more questions in our live audience chat here, but I am seeing a lot of love for our panelists here, all by name. Mike, Dr. Cardone, Dr. Findley, lots of folks are singing your praises out there and thanking you for all you do for our community and caring for our patients. So thank you. As we close up our program tonight, Mike, I want to turn it over to you because you've mentioned, our 3-star rating and other awards for our cardiac programs. So I think there'd be some value in our audience hearing from you about what these awards really mean for patients. So can you walk us through that?
Sure. So I just briefly, and I became took a leadership role for cardiac surgery in 2011. So, and at that time, we had a new surgeon that came here, Alex Nam, and then Dr. Cardone came shortly after. And one of the things that I told him when he first came, that my goal was to make this program a Thomson Reuters top 50 hospital, which eventually became IBM Watson. And I think a lot of people get caught up in banners, and I don't necessarily get caught up in the banners and the awards. But what it really means is this. when you are trying to reach that goal, the only way to do it is to measure your performance and compare yourself to other programs that are doing well. And so you establish processes and protocols and you adopt best practice protocols for your program, whether that be in transcatheter valve, whether that be in your STEMI program or your cardiac surgery program. And that's what helps to generate the results that the patients have, to be honest with you. So we look at blood use, we look at early extubation, we look at atrial fibrillation prophylaxis. We look at all those things. And in cardiology, they're looking at door to balloon time. And from structural heart, we're looking at ways to reduce stroke and ways to reduce all the complications that occur after these procedures. And the only way that you're going to be acknowledged as an IBM Watson Top 50 program or a 3-star transcatheter valve program is if your performance far exceeds anybody that's within your region. And so we are compared to, when you look at transcatheter valve, basically the rating has to do with the incidence of a number of complications, such as stroke, mortality, renal failure, and major bleeding. And another has to do with the quality of how it's implanted, whether the valve is leaking itself. So that has a lot to do with the performance of the interventionalist and the heart surgeon. And so they're looking for the absence of those types of events. And our program is the only 3-star program in Virginia, as I mentioned, but it's in the top 7% in the country. And so, our executive leadership likes to say that we want to provide the best care for the people in our community. But the reality of it is that we're providing the best care that you could possibly get in the country from a transcatheter valve standpoint. And when you looked at IBM Watson, we were a top 50 program, and they're rolling periods. So it's not a one-off. It's not 1 year. It's 3-4 years of rolling data that they're looking at. And it's just, I think, a testament to the commitment that Dr. Cardone, Dr. Na, Dr. Finley, Dr. Shonda, Dr. Ian Torno, all these interventionalists, and I don't want to miss anybody. This is an award show. But, when you have executive leaders that say, we want to invest this money in a hybrid room, in a cath lab, in an operating room, in this technology, and pull all these people together in a heart team approach. So whether it's a TAVR procedure or whether Dr. Finley's in the lab with a patient and says, hey, look, this cath looks kind of dicey. What do you think? Should they get a bypass surgery or should he get stents? And so it's that process. And then when you add in those things that we put together so that we're reducing blood use so you don't get kidney failure, we're getting you off the breathing machine so you don't get pneumonia. All these things kind of synergistically work together. They improve, I think, the healthcare and the whole health system, and not just in cardiac services. But I think it just reflects the fact that if you come here, you're probably going to have a better outcome than you would if you went to another place. And I think in this community, for some folks, I hope they see that. I know that that's hard to believe sometimes, because when you look at giant health systems, all the people that you're looking at on this screen, we've all been there. I mean, I trained at the Cleveland Clinic, and Dr. Cardone was Allegheny General. Dr. Finley's got a list of amazing places on his resume. But we have the capability of providing the best possible care right here in your neighborhood. And that sounds cliche, and it sounds like it's something that's on a billboard. It probably is. But it's true. It's true. And so I think that the 3-star reflects all that work that all these people do, because there's nurse practitioners with our structural heart program, and with the cardiologists, there's nurses, there's therapists, there's just a whole legion of folks that are all committed to these same things that we're talking about. So it's a big team. It's not a small team, and it's not the 3 of us here. That's for sure. So hopefully that explained it.
Yeah, that's great, Mike. Thank you. I'll try not to read too much into the message on the billboard. uh, since I am working in the marketing department, but very well put, Mike. And just to highlight your comments that we do offer the very best care in the state and even in the nation for this type of care, and it's something that is not episodic, right, Mike? It's not like you're good one time. You have to be good all the time to achieve these ratings.
6 years in a row for us. Well, 5. Yeah. So
amazing.
Yeah.
And we're getting more comments in, just I think from members of our team, just being grateful to work with you all. So that's, I feel like, a great note to end on tonight. We've had great participation from our live audience. So I just want to thank you, our panelists, for sharing your time and expertise, and also send a huge thank you to our viewers for tuning in and being so engaged with Ask the Experts. If you have questions about cardiac care, or if you want to learn more about our services, we invite you to visit our website for additional resources. You can find us online at heart.mwhc.com. And you can be sure to watch the Mary Washington Healthcare Facebook page and other social media channels to stay informed of the latest health and wellness information in our community. Again, thank you so much for joining us this evening. Please stay safe out there and have a great night.
Thank you.